I am delighted to have the panel speaking to us today who are going to tell us what the Oregon data tells us. They have been looking at the official data from Oregon, looking at Oregon Health Department's own reports. I'm going to start off with Anna Worthington, who has a Bachelor of Science degree from Wake Forest University and is currently a postgraduate student at Oxford University. And she's a researcher for Baroness Grey Thompson, who's sitting next to me. She's going to run through the Oregon Health Authority's most recent report on assisted suicide. So that is 24 years worth of data now that she's analysed for us. I'm going to swap places so she's center screen.
Hi, everyone. Thank you for having me here today. Today, I'm going to be discussing Oregon's Death with Dignity Act data summary from 2021. Next slide. In 1997, Oregon enacted the Death with Dignity Act, which allows physicians to prescribe lethal drugs for patients within 6 months of the end of their lives. Annually, the Oregon Health Authority publishes a report which contains a variety of important information, including participation data, patient characteristics, clinician characteristics, and information on the drugs prescribed in the dying process. The Oregon Health Authority has recently published its annual data report for 2021, making 24 years of data available for over 2,000 adults who have died under the Death with Dignity Act. Next slide. In 2007, a group of international colleagues wrote a report which claims that assisted suicide legislation in Oregon does not put vulnerable groups at risk. They wrote, "Rates of assisted dying in Oregon showed no evidence of heightened risk for the elderly, women, the uninsured, people with low educational status, the poor, the physically disabled, minors, people with psychiatric illnesses, or racial or ethnic minorities." In today's presentation, I aim to reveal that while this may have been the case in 2007, it certainly is no longer the case in 2021. Next slide. The Oregon 2021 report reveals 3 concerning trends. Firstly, an exponential increase in the number of assisted suicide prescriptions and deaths. Secondly, changes in the sociodemographic traits and end-of-life concerns of participants. And finally, an expansion of patient eligibility to typically non-terminal and treatable psychological illnesses. We conclude that assisted suicide is an increasingly attractive option for patients who cannot access or afford quality end-of-life care, who fear the financial implications of care, who feel like a burden on their loved ones and caregivers, and who have typically non-terminal or treatable psychological illnesses. Firstly, the 2021 data report reveals an exponential increase in assisted suicide prescriptions and deaths. On an average, prescriptions increased 13.6% annually, and assisted deaths 14.7% annually. Since 1998, there has been over an 1,000% increase in both measures. As well, in 2021, of the 383 lethal prescriptions written, 164 of these were either not ingested or their ingestion status is unknown. This is significant because the location of unused lethal drugs is not monitored in Oregon. Next slide. The 2021 report also reveals changes in the sociodemographic traits of participants, namely insurance status. In the first 10 years of practice, between 1998 and 2008, up to 88% of participants had private health insurance. In the past 10 years, however, we have seen a significant decline in the number of assisted suicide participants who could afford private health insurance. In 2021, only 21% of participants had private insurance, and the vast majority, 79%, had only government insurance, Medicare or Medicaid. Medicare is an insurance option for adults over the age of 65. It is federally regulated and therefore it does not cover the cost of assisted suicide. Medicaid, on the other hand, is an insurance option for any adult of any age who makes an annual income below the poverty line. It is state regulated and therefore in Oregon, it does cover the costs of assisted suicide. Notably, the Oregon reports do not differentiate between Medicare and Medicaid enrollment, which can make it difficult to determine the financial circumstances of participants. However, what we can conclude is that assisted suicide participants in Oregon are disproportionately covered by government-sponsored insurance in comparison to national averages. In 2020, 64% of adults in the US under the age of 65 and 40% of adults in the US over the age of 65 have private health insurance. This is 2 and 3 times the number of assisted suicide participants in Oregon who could afford private health insurance. Next slide. The 2021 report also reveals that there is an upward trend in the number of participants who are concerned about the financial implications of care. In 1998, 0 participants were concerned about the financial implications of care. In 2021, however, this is true for 1 in 11 participants, or 8.5%, and this trend is rapidly increasing. Next slide. The report also reveals that being a burden on caregivers and loved ones continues to be a significant concern. In the first 5 years of practice, between 1998 and 2002, an average of only 33% of participants were concerned about being a burden. Since 2017, however, over 1/2 of assisted suicide participants in Oregon have held this concern. Next slide. We have also seen an expansion of patient eligibility to typically non-terminal and treatable psychiatric illnesses. In 2021, conditions that led to assisted suicide requests include arthritis, complications from a fall, hernias, sclerosis, and notably, for the first time, anorexia. This is particularly concerning as the number of patients referred for psychiatric evaluation has only decreased. In the first 5 years of practice, up to 37% of participants were referred for psychiatric evaluation. By 2003, this figure was down to 5%, and in 2021, less than 1% of participants were referred for psychiatric evaluation. Next. The report also reveals systemic failures in detecting coercion and abuse. Many doctors who prescribe assisted suicide drugs have no or little relationship to the patient prior to the assisted suicide consultation. In some instances, the patient-doctor relationship lasted 0 weeks, and the time between the patient's first request and death lasted 0 days. Notably, in 2021, one doctor wrote 47 prescriptions in just 1 year. Changes in the law only exacerbate this issue. In 2021, 20% of participants were exempted from the 15-day waiting period, and out-of-state participation is now allowed. There are also significant data limitations revealed by the 2021 data report. Firstly, there is no independent pre-evaluation or post-mortem review of assisted suicide cases. As well, rejected assisted suicide requests are not documented. All of the data relies on the prescribing doctor. Data is also destroyed after 1 year, which makes retrospective research impossible. In conclusion, the Oregon 2021 report reveals 3 concerning trends. Firstly, an exponential increase in the number of assisted suicide prescriptions and deaths. Secondly, changes in the sociodemographic traits and end-of-life concerns of participants. And lastly, an expansion of patient eligibility to typically non-terminal and treatable psychological illnesses. We conclude that assisted suicide is an increasingly attractive option for vulnerable patients who cannot access or afford quality end-of-life care, who fear the financial implications of care, who feel like a burden on their loved ones and caregivers, and who have typically non-terminal or treatable psychological illnesses without any requirements for psychiatric evaluation. Next slide. In summary, there is a false sense of confidence in Oregon's assisted suicide safeguards. The 2021 report reveals that vulnerable patients are increasingly attracted to assisted suicide as a fast and affordable end-of-life option, which does not place burden or financial strain on others. Thank you.
Thank you very much indeed for that work and the analysis. I think we'll go straight on now to hear from Claude Regnard. Claude is an honorary consultant in palliative medicine at St Oswald's Hospice in Newcastle, and he's going to look at the impact on palliative care in jurisdictions like Oregon, which have legalized assisted dying. So Claude, if we can hand over to you.
Thank you very much. Yes, I wanted to look at the relationship between palliative care and assisted dying, because there have been a number of claims very recently that really the two get on very well together, and there's a cozy relationship. Although a recent article said there was fierce friction, which is surprising, and they were surprised because they felt the goals were shared. Now, some of these comments puzzle me for several reasons. For example, let's look at growth in palliative care services. And this is services in Europe from 2005 to 2019. The assisted dying countries were Switzerland, Netherlands, and Belgium. And there was growth in those assisted dying countries. But when you look at Western European countries that do not have assisted dying, the growth is much faster. And in fact, most of that growth that you see there in red is actually Switzerland, because since 2012, Dutch and Belgian palliative care growth has completely stalled. And that means that over the 10 years, as the need for palliative care has increased, it has not been matched by palliative care. So in fact, palliative care in those two countries is actually being eroded, and that's a serious worry. If we look at hospices, it's interesting that 15 years after legalization in Oregon, 2/3 of the hospices were refusing to take part. There doesn't seem to be a cozy relationship there. In fact, recently in New Zealand, except for one hospice, all New Zealand hospices have refused to take part in assisted dying. Again, where's that cozy relationship? And we have to bear in mind that when people talk about hospice in Oregon, it's very different to the UK. It's mostly home care nursing, rather like UK district nursing. Doctors don't even have to be a palliative care specialist. And that's quite unlike the UK. Many are for-profit services, and that has huge implications. For example, the patient has to agree to be no longer eligible for disease-reversing treatments. And you may say, well, that's obvious, but what it does, it prevents access for symptom control for radiotherapy, chemotherapy, surgery, nerve blocks, spinal analgesia, all vital things that we can access in the UK. And in Oregon, there's no information on the percentage who are receiving UK-like specialist multidisciplinary palliative care. So claiming hospice involvement is really meaningless unless you know exactly what that means. What about the wider issue of end-of-life care? How do assisted dying countries do? Well, the answer is they rank pretty poorly. Belgium is 26th, Canada is 22nd, and what you'll notice, with the exception of Switzerland that's gone up a couple of places, although it's still currently 13th, that all of them have actually got worse in the last 6 years. And that's the opposite of what is often claimed. So we look at that in palliative care and go, I don't see a cozy relationship there at all. And the issue of suicide has come up a lot recently. We know, as Anna has shown, that numbers have increased markedly over the last few years. Now, if it is true that legalizing assisted dying reduces non-assisted suicides in people with serious illness, and bear in mind the numbers of people with serious illness in Oregon is about 10 times that of the number who are committing non-assisted suicide, we should be seeing a reduction or at least a leveling out, but the exact opposite is true. And in fact, non-assisted suicide rates in Oregon have increased by 1/3 since legalization. I'm not suggesting that there's a link, but what it does show is that legalizing assisted dying does not reduce non-assisted suicide rates. And that's contrary to the claims that have been made in recent days. There's also an impact on staff. Assisted dying has a psychological impact on up to half of healthcare professionals, an impact that persists long term in up to a fifth. Doctors in Victoria, Australia are struggling to do eligibility assessments, even struggling to get to know the patient, let alone reconcile their own role in assisted deaths. And in Canada, those who refuse to participate in assisted deaths are not refusing, as is often claimed, because of religious or moral grounds. They're refusing because of the emotional burden and fear of psychological repercussions. So the issue is there's a profound and often negative effect on healthcare staff. So who's going to provide the additional staff to counsel them and replace them when they need a break? And safeguards. Safeguards in every legislature have been weakened or removed, and that includes Oregon. Bear in mind, in the UK, there's already an organisation, My Death, My Decision, which is campaigning to remove the 6-month prognosis safeguard. So it's happening now already. People say, well, listen, assisted dying already goes on illegally in the UK, and legalising it would remove that. Well, the evidence doesn't support that. In Belgium, 48% of Belgian assisted deaths are not reported. In 18%, that's because doctors say it's too big an administrative load. 1 in 5 assisted deaths are not reported. And it's quite common in parts of Europe for something called continuous deep sedation to be used, and it's used as a cover for euthanasia. This is quite different to what we call in the UK palliative care sedation, where we titrate the drugs to the symptoms, not more, not less. And a recent study in Japan has shown that that doesn't hasten death. So there's no evidence that illegal activity reduces. In fact, it may actually get worse. And as mentioned about financial issues, this is a graph showing the concerns that Oregon patients, assisted dying patients, have about financial concerns about treatment. It was 8.4% last year, nearly 1 in 10. And you may say, well, that's a different funding system for healthcare. But actually, social care funding is a major issue in the UK, and there are many residents in care homes and nursing homes who are very worried about how they and their families are going to afford the care. It worries me that it's quicker in Oregon to get an assisted death than it is to get a wheelchair. In some patients, 20%, as Anna's mentioned, the 15-day cooling off period has been removed. I checked yesterday, and the current waiting time for an NHS wheelchair in the UK is 18 weeks. If only assisted dying patients had that length of time to consider their decision. And if we look back on our record of safeguarding, it's not good. We're still failing to implement a major safeguarding legislation, the Mental Capacity Act, 15 years, more than 15 years since it was introduced. And unfortunately, vulnerable people in the UK are still dying prematurely because of poor decision making. If you want to check it, check out the confidential inquiry for premature deaths in people with learning disability, the CPOLD inquiry. Palliative care's foundation is safeguards, whether it's physical, psychological or social. What we are not seeing is those safeguards in assisted dying. And I want to suggest something about the decision-making process that's going on. The reality is, as doctors, we're not trained to detect coercion and manipulation. We're not lawyers. We're poor at detecting depression, perhaps a bit better in palliative care, but we still struggle. We still struggle in some situations to assess capacity. As for suffering, we have no method or tool anywhere in the world that estimates suffering. And we're not good at estimating prognosis, especially in non-cancer like motor neuron disease. In cardiac disease, half of prognoses are wrong. Even terminal diagnoses are wrong in 5%, and all of us in palliative care can give stories of people who have been referred to us and we find that they're actually not dying of a terminal illness. The reality is that as doctors, we are biased and fallible because of our compassion. It actually results in us being exposed to unconscious bias. And I would suggest that doctors are the weak link in deciding on and practicing assisted dying. So we look at, in palliative care, we look at situations like in Canada, where assisted dying is a legal right, but palliative care is not. And we go about that and go, that's iniquity. And in 2017, Hospice UK found that nearly 120,000 UK patients couldn't access specialist palliative care. And we tell ourselves, well, surely isn't that the priority? And I can't find any evidence that palliative care improves with assisted dying. In fact, the very opposite is more common. And I worry that doctors are being used to legitimize assisted dying, and I certainly object to palliative care being used to grease that process. Therefore, it should be no surprise to you that palliative care remains deeply distrustful of assisted dying. Thank you for listening.
And I think we'll go straight on to Bill Toffler from Oregon. He's Emeritus Professor at the Oregon Health and Science University and a National Director of Physicians for Compassionate Care Education Foundation. He's going to build on what we've heard from Anna and from Claude and talk about why there's an inherent conflict in the medical profession from his experience as working as a clinician in Oregon. Bill, over to you.
I appreciate very much the opportunity to share my perspective, having lived in Oregon for 40 years. So I've been here both before and after the passage of assisted suicide, and it's radically and fundamentally changed the perspective for end-of-life care in Oregon. And it's in my mind, it's not for the better. You know, after 27 years, as Anna said, we now have in Oregon, supposedly the bellwether state, we have 9 other states that have legalized assisted suicide, and one, the judge in Montana ruled that it was okay, a doctor would have a defense. The other entity is the District of Columbia. But what I want to share is that 40 states have not passed it. In fact, 38 states have actually strengthened their laws against assisted suicide, 4 of them just in the last year. So I think what I'm trying to say is that many states have looked deeply at the Oregon data and have found that it's not what it is cracked up to be. And so literally hundreds of efforts have been made to try to pass it. As we share the actual reality, as Anna has and as Claude, basically it is not at all being embraced by other states. There's terminology confusion. When it got passed in Canada, there's no distinction between a physician providing or administering lethal medications. So Canada looked at the Oregon data and found that we really had lingering deaths. It really wasn't an efficient way to end people's lives. And so to avoid Oregon's problems, they basically went ahead and had the idea that we would have injection just as you do with capital crimes. So basically they are avoiding Oregon's problems with lingering deaths. So literally the quote, I'm quoting from the man who woke up 67 hours later and he said, what the heck happened? I thought I was supposed to be dead. And so literally you have teams of people working on a cocktail of deadly drugs without any kind of supervision. And that is a reality in Oregon. So if you can move to the next slide then. So I want to go through why it's a problematic paradigm, right? Who's paying for it? Who's asking for it? Who's really deciding? Who's helping? Who's eligible? Who's coaching? Conflicted and profiting. I'm going to put some flesh on the actual raw statistics that both Anna and Claude shared so amiably, and then the societal impact as well. Next slide. This is a case of one that came to light because there's a shroud of secrecy over most of these issues because all the data is second and third hand reported. This one came out in the papers though. A 64-year-old retired school bus driver, Barbara Wagner, she had metastatic lung cancer, was in remission, it recurred. Her oncologist wanted to prescribe Tarceva, a drug that would have given her a 46% increased chance of being alive in a year. The Oregon Health Plan, as Anna was saying, is now covering many of these people, and they will pay 100% for assisted suicide, but they wouldn't pay for the chemotherapy. The Oregon Health Program medical director said it's necessary to point out options that are available, And essentially, assisted suicide could be considered as, quote, comfort care, end quote. And this is the idea that the solution to suffering now in Oregon is to end the life of the sufferer. Next slide. So who is asking? There's a picture of Kate Cheney and her daughter, Erica. Kate Cheney is a survivor of the Holocaust. She had some mild dementia. As she went to a psychiatrist at my former institution, Oregon Health and Science University, Dr. Ganzini, the psychiatrist, said, it isn't really clear who's asking for the assisted suicide. And her quote was, the daughter, Erica, seems to be coercive, end quote. She went to a second doctor, a psychologist. He didn't use the word coercive, but he also wouldn't sign off on the suicide. She then shopped for a third doctor in the Kaiser Foundation healthcare system. And it was Dr. Goodwin who said she's a candidate for it. 2 weeks later, she's dead. Next slide. Who's deciding? My former colleague, Dr. Eric Walsh, was a family physician who went into palliative care. He's actually the doctor who did the assisted suicide for Brittany Menard, the famous young woman, 29-year-old with brain cancer. And on 60 Minutes, a program where Dr. Walsh and I were both featured, he answered, when is palliative sedation used? And it's when the physician decides that suffering is intolerable, the physician prescribes a medication which puts the patient in a coma. And again, this is very different than what Claude talked about, where you have palliative sedation helping the symptoms rather than putting a person into a deadly state. Next slide. So who's helping? There's a case of Patrick Mathena, a man who had cyclical depression. He had Lou Gehrig's disease or amyotrophic lateral sclerosis. He struggled to swallow the deadly mixture. And his brother-in-law, Joe H., quote, helped him to die, end quote. He would not elaborate on how. And so the Attorney General of the state of Oregon offered to modify the law. His intent, of course, was to make it legal for injections at that time. That's the first effort to expand the technique of ending the law, because indeed, taking overdoses is really not equal treatment for disabled people with swallowing difficulties. And so it really violates the American Disabilities Act, as all of the members of the Not Dead Yet group, which are disabled people, realizing this law is putting them at risk. Next slide. So who's eligible? I show you this picture because it's very hard to look at this picture. Obviously, two people who love each other and are enjoying life. And literally the lady on the left is Lavelle Svart, who did a video log in the Oregonian and actually used to work for the statewide newspaper, the Oregonian. And she wanted to show how she's going through this. She's holding a party. They literally were dancing the polka, having a good time. Again, it'd be hard to tell who's terminal here. Next slide. So here you see her actually taking the deadly mixture, and out of, I guess, respect for, they didn't do a video of this out of respect for this process, but the man standing next to her is not her husband, it's not her doctor. It's actually the lawyer, George Amy, for the so-called Compassion and Choices group. And he's coaching her on how to drink the deadly cocktail, because basically it's so bitter that it burns the esophagus when it's being swallowed. And he basically is trying to tell her not to drink it too fast, not to drink it too slow. If you drink it too fast, you may vomit it forth, even in spite of the antiemetics and motility agents that are given a half hour early. And he's then basically trying to give her help. She's actually saying, in the last words of her mouth is, this is the most, and I'm quoting, god-awful mixture drink I've had. And she ends up going to sleep. And in a very dispassionate clinical fashion, he describes those things to the people that present. Yeah, thank you. So who's conflicted? Dr. Claude already referred to hospice dilemmas. And indeed, they used to not go into the site because it was such a conflict of interest, but now they actually do go in and they're a part of it. And so these are quotes from hospice personnel. By advising them, I was part of it. I kind of regret that I did that. It was really part of the act. It can create turmoil for the family. Indeed, it can. In fact, there's a family that father came up from California, just like Brittany Menard, to do the assisted suicide in Oregon. And basically, we're going to do it. He was going to do it on Easter Sunday. I knew the doctor involved, so I told them the family's dilemma, and they moved the date. But again, just totally out of sync with what family wishes are. I tried to talk her out of it. I don't know if that's our role. Well, of course it is. In suicide, we do try to tell people that they are worthwhile, even when they don't see their own worth. That's the job of psychiatry and all family physicians. So it's kind of antithetical to hospice. Next slide. Who profits? This is a case in Bend, Oregon. Thomas Middleton, he had Lou Gehrig's disease. He moved in with Tammy Sawyer, who was acting as a caretaker. He named Sawyer as a state trustee, told her to put the home in a trust and not sell it until the market went up. 2 days after her death, she deposited his money into her own account and put the house up for sale, didn't follow his wishes. She was indicted for criminal mistreatment and aggravated theft. You can say, well, she got what was supposed to happen. Well, that would have never come to light had it not been for other nefarious activities by Tammy, because the whole thing is under a shroud of secrecy, as I said. Next. So there is a slippery slope. The eligibility is extended to our efforts to try to pass it, bills to extend it to 12 months, includes now starvation for demented patients. Ingest now is a bill was put forth to include IV injection. Again, it's inefficient to take overdoses. State bills to include a PA, a physician assistant extender in Hawaii, to avoid conscience protection for doctors in Vermont, and a study of barriers, which is just a prelude to breaking down those barriers. We have injection for children in Belgium, psychiatric care centers allowing euthanasia for mentally ill. Now the disabled are at risk in the Netherlands, and those who feel like they completed a life are eligible as well. Next slide. So this is the essence of really the inherent conflict of interest. The Secretary of the College of Medicine in Quebec asked the following question: if the goal of euthanasia on demand is based on a right, are we still talking about medical aid in dying, or simply aid in dying? And what then would the medical profession have to do with it? It's really not rocket science. Why are doctors doing this? It's just been sold on the basis of trust, and the doctors know the person best. And Anna gave the data about that. That's not true. Next slide. So it's an inherent conflict of interest for the medical profession. It's a corruption of the integrity of palliative care and hospice. And if the so-called death with dignity is embraced by a society, the activity should be performed by some entity outside of the medical profession to avoid that inherent conflict of interest. I often say it's a little bit like a lawyer or a barrister in your country protecting the defense interests and then walking across the aisle and actually helping the prosecution. And if you don't think that's a conflict of interest, it's also acting as the judge deciding which lawyer has the better argument. And worse yet, it's the executioner in a capital punishment case. So I ask you to consider this and not make Oregon's mistake. Thank you.
I'm going to hand over to the chair of our APPG, Danny Kruger, to go into discussion. I'm not sure if we've got some questions. Danny, do you want to come and sit here? And then you're a bit more in the center of it. I don't know if we've got questions that have come up in the room and if we've got questions that have come up in the chat, but we'll have a look for those. I think we've had some very revealing data, hard data, and it's data which is published data. It's been through peer-reviewed journals, and it's the Oregon Health Department's own data.
Thanks, Laura, and thank you, everybody. Really very, very powerful presentations. Thanks particularly to Anna, who's the researcher for our APPG here, for all the work that she's been doing, collating the data on Oregon in particular, and to our professional colleagues who've joined us today. So, Sophie, can you let me know if there are questions that are coming in online? But before that, I might go to Tally Gray-Thompson, if that's all right, to give any reflections or questions to the panel.
Thank you. I've actually just got a question on assisted suicide being expanded to people with anorexia, which I think most people I speak to are fairly terrified by it. And I was just wondering whether Bill could possibly just expand on that a little bit more, and whether you've got any more information on the numbers it could affect. I come from a sports background, and actually eating disorders is a really big issue with young athletes. And I'm kind of worried about the numbers that could then fit into the system.
I think we should introduce Carl Benzio, who's a psychiatrist who deals particularly with young people with all kinds of gender dysphorias and these type of issues. particularly, who do seem to be a group who are now at risk when we look at some of the official data. But should we go to Bill first and then to Carl?
Well, we've had these exceptions, and I'm looking forward to Carl's comments about this, but the reality, we've had exceptions like anorexia. We even had exceptions for diabetes who stop using their insulin. Would they be eligible? They might live for 20 years managing their insulin. With the new technology, they could probably live as long as people without diabetes, with being able to monitor with subcutaneous monitors and the technology involved today. I have diabetics that are basically not at all different with their A1Cs than people who are non-diabetics. It's amazing. So this is now a person who's eligible. Anorexia has snuck in here recently, and it's just a sad reality. This is a potentially a lifelong illness. And so there just is no limits to people who believe this is a solution to suffering. And Carl, maybe you want to comment on that as well from a psychiatric point of view.
Sure. Whenever somebody is trying to kill somebody or kill themselves, we that's always been looked at as aberrant and something that's not natural, not normal. There's something wrong in that situation, and that person needs to be helped. There needs to be some understanding as to why they're thinking that, why that's the decision they want to make, and we want to provide help and we want to provide treatment. When somebody comes into the ER and they have suicidal thoughts, we even take away their rights and we hospitalize them against their will because we want to save them. We're helpers, we're healers. We want to jump in and try to treat the underlying struggle that person has, the fear, the hopelessness, they've maybe tried to change and they've had difficulty, but most people usually haven't had a psychiatric evaluation, first of all, and then second, if they have, well, what's a significant course of treatment to allow that person some help? Whenever somebody has a significant medical issue, we expend a lot of money, whether they've had a heart attack or diabetes or were in a motor vehicle accident or whatever. We expend a lot of money to help diagnose surgical intervention, treatment, and then ongoing treatment for cardiac rehab or whatever the particular medical illness is. But from a psychiatric standpoint, we do very little to take a look at whenever somebody is suicidal or is hopeless or is despairing or they're afraid of their future. They're fearing not necessarily pain. Most of the situations that a person signs up for physician-assisted suicide is more from a fear of the unknown or lack of control, lack of power, not necessarily for pain and increased pain that they might have. So, how do we jump in and really show compassion by coming alongside the person? People aren't pets. Pets we euthanize because there's not a spirit, there's not a deeper psychological element to a pet. Whereas people, we don't own people. We don't, we don't toilet them. We don't, take them around on walks, and we want to treat them with dignity and care. And we just at the first sign of their quality of life just isn't quite right, or there might be some suffering. Well, let's just treat them like a pet and put them out of their misery. That's such a demeaning process. And I think with good psychiatric care, with evaluation, with intervention, as a psychiatrist in a medical facility, whenever somebody refused their cancer, medication or their chemotherapy in the ICU, they would call the psychiatric consultation and call me in and say, hey, is this person competent to make this decision, to stop either to pull out their tubes, to stop the ventilator, to stop their chemotherapy? And there'd be a psychiatric evaluation. But in so many of these cases, there is no psychiatric evaluation. As we saw, it's less than 1% now, a psychiatric evaluation, let alone any treatment or intervention to help come alongside. To expand this to such treatable things such as anorexia, depression, anxiety, PTSD, we're in a behavioral health pandemic. And, with, COVID and even before COVID, but then COVID has certainly accentuated it. And if we're going to go to this as the treatment of choice for situations after just, 1 day or 10 days of, an evaluation, then a second follow-up, these treatment situations need to be a lot longer than a 10-day waiting or even a 1 month waiting to really get involved in these situations.
Let me add to that, Carl, because the reality is there was a study of psychiatrists, none of whom are a very small minority, 10% thought that they could make a reasonable judgment of a major depressive disorder with a single interview. in Oregon. This was a survey in Oregon. Linda Ganzini, the same psychiatrist who found Kate Cheney to perhaps having a desire by the daughter, Erica, rather than from her, and thought that the daughter was coercive, actually is a pretty honest researcher, probably the most published researcher in the state of Oregon about assisted suicide, if not the world. And the reality is that she's pro-assisted suicide, yet she has the integrity to say that 1 out of 4, 1 out of 6, depending on how you read her data, are depressed, and they were not diagnosed by their doctor. So they were not given treatment. And in fact, Patrick Matheny, the patient, he had cyclical depression, and he was living in a trailer in the back of his parents' yard. The overdose went through the mail from my institution to his home. And that was, again, no doctor present, no involvement. It's very much, I would term, dispassionate care, not the so-called compassionate care.
And I think when we look at the studies too, there's major depression or clinical depression that is the big one that has the research around it and has the most strictest criteria. 9 symptoms, and you need to fulfill these within it. Having these symptoms for a 2-week period. But there's so many other depressions that don't rise to the level of major depression that are depressive disorder, what we used to call NOS, or unspecified or specified depression. So to me, the bulk of these physician-assisted suicide cases are those that not just major depression, which is about maybe a quarter of those cases and probably more, but all those unspecified or subclinical depressions that don't rise to the, they don't have all the criteria, meet all the criteria for major depression, but certainly meet some of the criteria for major depression. They would be diagnosed as unspecified depression or anxiety disorders or addictions or, so many other anorexia and other clinical syndromes that are they're very treatable situations. As a physician, we're called to help people. We're often the last voice when a person isn't competent, or they're not clear thinking, they're not making good decisions, or they're in a coma, or they're a youth, or they're have intellectual compromise. We're the ones that are the last voice protecting people. So to interfere with that process, if a person, I'm called to help people that want to attempt suicide, and so many people that have attempted suicide, after they've survived, you ask them, well, how do you feel? Like, I'm so glad I'm alive. There's some intervention. Now that doesn't mean they might not try again in the future, but their reassurance, their elation, their oh my gosh, I can't imagine. I was thinking that the relief they have of actually being able to breathe again and engage in this world is profound in those situations. And so if a person does want to die, that's between them and God. That's between them and their family. But to bring a physician in, as we talked about, to bring the healthcare profession in, really jades our societal view of physicians, of healthcare professions, and really undermines that doctor-patient relationship, which is so important, in that treatment process. We need a patient to divulge all their information to us, knowing that we're going to be helping them sustain life and move forward in life as much as possible.
Let me jump in, if I may, quickly. There's a number of questions we've had in online. We've only got a few minutes left. I'm just going to quickly run through them and turn to each of you, particularly Anna, Bill, and Carl, on this first question, which is about the states in the US which have not gone down the assisted suicide route. Can you just, one of you or each, just quickly give a word on what do you think it is? Is it the evidence? Is it political? Is it ideological? What is driving the, as it were, the resistance in the US to assisted suicide?
Well, I think it's the evidence, and it's the evidence, and physicians don't want to take part. I mean, in Bill's state of Oregon, he can tell you that it's such a small infinitesimal percentage of physicians that are part of that. That provide physician-assisted suicide. Physicians don't want to be part of it. We don't want to taint our profession. The people don't want to see their physicians be part of these death doctor. That they want to trust their doctor. They want to be able to go to them and know they're going to get help that prolongs their life, that treats them with compassion, that comes alongside of them when they're suffering, not pushes them off and discards them to the side and say, hey, take this, and this lawyer will hang out with you while you take your concoction.
Thank you, Bill.
I totally agree with Carl, but it also is political. There's no question. The euphemisms, the so-called death with dignity, as though people who die, like my late wife 8 years ago, this coming month, died at home peacefully with good palliative care, good pain medication control, despite her air hunger, despite other issues, and that supposedly then isn't dignified? I mean, what a horrible euphemism. And when you use a euphemism like that, how when somebody is despondent in a state, whether it's a teenager or 20s or 50s or whatever, and you've told the culture that killing yourself is dignified, is an anathema to what has always traditionally been the case. When I was in Australia talking about this, I remember seeing an article about 3 people, 2 daughters and a mother, who all had a triple suicide. And at the end of the article, they had, if you're feeling badly, you should call this number. Well, what is that? That is society recognizing that these can be suicide contagion, and this can be something that is harmful to society. It's when people have desperate thoughts, they should be supported, not killed. I mean, without being facetious, once I was so sick with the flu at home, I said something along the lines of, you know, just get a gun and shoot me. Obviously, my wife didn't, but the reality is that that's the kind of feeling we have, and we need to respond to humans who have these desperate feelings and support them, reflecting their worth, even when they don't feel it themselves. And I've done that over and over again with patients. It's very effective. People say, why? What difference does it make to you? I say, well, you know, I like talking to you. And with that, the patient reached out for the first time, got a little tear in her eye. How we respond is everything. I cannot go down that path and have integrity. One of the things, one of my patients asked me, is he, referring to the oncologist taking care of her, one of the death doctors? Such a question was impossible 25 years ago. There was integrity throughout the profession. There was a uniform standard.
Okay, Bill, just on this issue about capacity, I'm going to actually turn to Laura, if I may now. We've had a question about people who are with anorexia, very low body weight, whether they have the capacity to make the decision. And while you're responding to that, just pick up on we've had a study released this week in the UK showing numbers of suicides and attempted suicides by people with terminal illness, which has excited the Dignity in Dying Brigade.
Okay.
So, Laura.
Capacity assessment is very difficult. You can't just do it as a one-off. It's not a quick questionnaire. It's about whether people really understand the implications for themselves and for others, and that whole decision-making cycle. And most doctors are not good at assessing capacity, and they are not good at supporting people with impaired capacity to fully understand the implications of their decisions. So you can't just take it at face value. The data that Danny's talking about is data from the Office of National Statistics, which looked at people with poor prognosis cancers. Those cancers, one could understand, were poor prognosis. It also looked at people with chronic obstructive pulmonary disease and also with ischemic heart disease. And that's really odd because those patients with treatment actually have a good prognosis. So it didn't, but the one thing it didn't do was it didn't look to see if they had any mental health issues. So they assumed that none of these patients had mental health issues. And when they compared them with so-called controls, there was no look at whether there were mental health issues. And also, there was no view as to whether they had had any support at the time that they were given the diagnosis. The data shows that their suicide risk was highest at the time of being given a bad diagnosis. We know that anyway, and we know that if that bad news consultation is badly handled, people's despair and suicide risk is higher. So again, they didn't look to see even the training of the people who have been giving that bad news diagnosis, nor how it was done. There's no look at the data of these people at all in terms of their clinical. So I think it's extremely questionable data. And it's quite bizarre because the publicity around it more or less said, well, people are killing themselves, so therefore we should help more people kill themselves. It's a kind of circular argument with no basis to it. But I think Claude's also can answer some questions.
Well, I would like to, in the last couple of minutes we've got, can I turn to, I'll come to you as well, Carl, but Claude, on this question of the impact on professionals that you mentioned earlier, could you just talk a little bit more about what we know about the effect on
Unmute yourself, Claude. Unmute yourself.
Well, yeah. Indeed, I mean it's quite frightening, really, the extent. And I'm not saying there aren't some people who are okay about it, but for many, it has a real impact in half of healthcare professionals, and that persists. They get a post-traumatic syndrome, which is really concerning. And we know from Leonie Herx in Canada that the impact on many doctors is quite profound, and that is reflected in Canada and in Oregon. Only 2% of doctors prescribe. In Australia, it's 1%. In Colorado, it's 0.01%. In other words, the vast majority of doctors, even if they felt that it was okay to legalize, they were going, don't ask me to be involved. And the reason is not a moral or religious reason. They're actually very frightened of the psychological repercussions they will have, not only on them as individuals, but on their practice.
Thank you. Thank you. Okay, Carl, do you want to come in again?
Yeah, and talking about the competency issue, you know, we can ask questions and people can give intellectual answers showing that they might be competent, but you really need to look and examine, well, how are they living their life and what are the decisions that they're making? That reveals whether they really have competence in making those decisions. And you talk about anorexia and certainly things that affect your brain and the nutrition to your brain is going to compromise decision-making functioning, but depression, anxiety, all those things are going to cloud our ability to see things clearly that interfere with competency in making these decisions. As we talk about allowing suicide to happen, as we saw the slide of the increase in non-assisted suicide rate in Oregon, when you have the authority telling people that it's okay to kill yourself, that has an impact on people's decision to kill themselves. Whenever you have the authority saying that life isn't valuable and people are just commodities that allow other people to get their needs met, that's going to increase suicide rate as we devalue people. And then as we aren't sure as to who is a death doctor and who's not, people are reluctant to share information, to share psychological information and other things with their doctors. So now they're not going to get the treatment and the interventions that are necessary to help them move forward and resolve some psychological and psychiatric issues that's going to further their depth of despair and hopelessness that leads to some suicides. That's why we see that increased suicide rate in those states that would have physician-assisted suicide.
We've really right at the end, we're right up to time, and in fact we've gone a minute over and we will need to stop. But I would like just to make one comment. I know Claude's answered it in the chat, but we do know that at the time of a bad diagnosis, when people's world falls apart, they suddenly realise their mortality, they are at particularly high risk of suicide. We've been trying to push the government to actually tell us what the suicide strategy is. And when I last asked it on the health bill, I was told that we would be getting it in due course, whatever that means. But actually, we do need to really look at suicide prevention strategies, and we do need to make sure that people have adequate support at the time of a devastating diagnosis and when they get recurrence and symptoms, because if you leave them with symptoms accumulating and accumulating, of course they get demoralized, and then they begin to think and actually come to believe that death is the only solution to their problem when it isn't.
I think we need to let people know that that last season of life is a rich season with much incredible opportunity and experience in it as well.
Correct. We must stop, I'm afraid. I'm just checking whether you have more questions. There are lots more opportunities to continue this offline, but we better stop our meeting. I'm very grateful to our professional guests, to Bill, Carl, Claude, Anna, Elora, and everybody. It's actually been a bit difficult but a successful year for us in the UK. We've managed to see off a very powerful effort on the part of the assisted suicide lobby to change the law here. They've had a bill in Parliament which was defeated. They've tried to pass an amendment to the health bill which was defeated. Meanwhile, an amendment proposed by Elora here was accepted by the government, which has made palliative care a core service of the NHS for the first time in its history. So we've advanced the ambition of the APPG for dying well, which is to improve access to excellent palliative care, and we have resisted the other side, which is to resist attempts to legalise assisted suicide. So a good year for our campaign in the UK, but it's not over. They will be back in the new session of Parliament, so we must all be too. Very grateful to all of our professional advisors and supporters. And our thanks to everybody who's taken part today. Thank you.
Thank you.